Thank you very much. Good morning. So the first thing about shoulder replacement is often in this sort of audience, I can stand up and people still say, really you do shoulder replacements? Well, the answer is we do. And the second thing is there's often a little bit of surprise that people of more elderly ages wish to go back to sport. And again, they do. But so shoulder arthroplasty is actually becoming increasingly performed. And perhaps unlike other replacements, which we're going to hear about, there is a lack of consensus regarding recommendations to give to patients about resuming their sporting activities. The NJR published last week, and if you look in the period of 2012 to 16, there were over 22,000 primary shoulder replacements performed, mainly in ladies, median age 73 years, but an age range of 17 to 99. And in the States, there's been an explosion, really, in terms of shoulder replacements. Why do we do them? Because, in essence, they do work. And you can see here in the end graph, the change in Oxford scores from pre-operative to post-operative, significant gain for the patient. So, is it easy to advise regarding sport? You would think so. Should be a fairly standard sort of process. But it isn't. And the changes that influence us relate to the prosthesis, they relate to the patient, the pathology, and indeed the surgeon. Shoulder replacement, shoulder arthroplasty, actually there's a number of different options that we have, ranging from hemiarthroplasty, which can be a resurfacing, stemless or stemmed, to total shoulder replacement, stemless or stemmed with different glenoid components, and reverse shoulder replacement. And these are just a sort of selection of prostheses that we might use. Resurfacings, about 10% of shoulder replacement is a resurfacing. Stemless or stemmed hemiarthroplasty, about 13%. To total shoulder replacement, 30%. Reverse shoulder replacement, massive increase in this, up to over 40% of replacements are now reverses. So those replacements reflect the pathology, and we can do replacements for trauma or elective concerns. You can see here that a total shoulder is normally largely done for osteoarthritis, 90% of the cases, whereas reverse shoulder replacement largely done for cuff arthropathy, again for a large number of cases, 60–70%. And those replacements relate to the age of the patient and thereby the pathology. So there's a skew normally towards hemiarthroplasty in the younger age, and this week I would add to that because I've done hemiarthroplasty in a 30-year-old female. To total shoulder, where you're looking about an average age of mid-70s. This week I've done one on a 50-year-old. Through to the reverse, which is the more elderly age group. So age does affect the procedure. The surgeon as well also will influence matters because surgeons like to get good results and we want success, not failure. And the sorts of failures that you will get from a shoulder replacement in terms of perhaps returning to sport may relate to instability, cuff insufficiency, loosening of the prosthesis or indeed fracture. And these are concerns with shoulder replacements. The overall risk or failure rate that we wish to obviously keep as low as possible is around 4% failure rate, both for trauma and elective cases. But the failure rate varies with age. So if you are 65, your failure rate at 4 years is over 7%. Whereas if you're over 75, the failure rate is about 4.4%. So surgeons can be conservative, and this study showed how surgeons view advice for return to sport. And the majority of surgeons would say that it takes about 5 to 7 months post-shoulder replacements in general to return to sport. A little bit quicker perhaps with the hemiarthroplasty, but certainly total shoulders and reverse shoulders are very much in that time period. This looked at a surgeon's attitudes to return to sport following a replacement, and in essence you've got procedures or sports with light impact here, where it's generally allowed or allowed with experience, through to sports with a full potential, where there was a lot more conservatism, and I'm not sure exactly what experience means, through to high-impact sports, where there were several sports where certainly surgeons would not advise return to sport. And interestingly, if you look at hemiarthroplasty and total shoulder replacement, there is a difference between North American surgeons and European surgeons in terms of whether they would allow people to go back to sport. The American surgeons are much more gung-ho. The European surgeons are more conservative in their advice. So if we take those considerations on board, does the literature actually help us in advising patients? Well, there's been 2 meta-analyses of the literature in the very recent past. This study, which is just about to come out, showed that only 9 of 35 studies on this topic met criteria, mean age 71. But in essence, the mean return to sport was about 80%. Interestingly, and perhaps importantly, all those that returned to sport were participating in sport in the 3 months prior to that procedure. There was a lower rate of return with the reverse prosthesis compared to other types. And in general terms, return to sport in shoulder replacement, you're about 80% for golf, 75% for swimming, and tennis is just over 60%. This was the second meta-analysis. They actually found 13 studies which met their criteria, but return to sport 85%, returning to equivalent or improved level of play 72%. And there was a high rate of return with total shoulder replacement, less in reverse, and in fact hemiarthroplasty came out as the worst performing prosthesis. So why is that? If you compare total shoulder with hemiarthroplasties, total shoulder, normally patients will demonstrate a better range of movement post-operatively, better functional outcomes, and improved satisfaction. But that has to be referenced about why they're having those replacements, and in general it's for osteoarthritis, whereas with hemiarthroplasty that could be a younger population, for example those with avascular necrosis or post-traumatic instability or something along those lines. So looking at hemiarthroplasty versus total shoulder, this paper supported that view with a higher return to sport after total shoulder compared to a hemiarthroplasty. The hemiarthroplasty patients had significantly increased pain and worse satisfaction. But there's also that variation with age, and we can see from this paper, which looked at total shoulder replacement in patients under the age of 55, predominantly for osteoarthritis, and they categorized their sports by low, medium, or high demand level and the use and extremity use. In this study, what it showed, 93% satisfaction rate, and that 96% of patients had restarted at least one sport at the average of about 6 months post-intervention. And indeed, many of these patients are saying that they want to have their shoulder replacements because they want to get back to their sport. It's not just about the pain and the disability, it's also about their functional abilities. And in terms of direct return, in this younger age group, fitness sports, nearly 100%, golf, very high, and as you would expect, as you move down the list, then there was lesser success rates for those returns. But again, 4 out of 5 patients returned to a similar or higher level. 90% were able to return to high demand sports, and over 80% returned to high upper extremity sporting activity. The interesting thing about that paper is, having said all that, they then caveat it by suggesting that caution should still be advised in the young active patients undergoing total shoulder replacements. So what do we need to think about? Well, certainly there's been a general conservatism towards doing total shoulder replacement, perhaps in the younger age group, because we fear glenoid loosening, and that has put some restrictions on what we allow patients to do. But if the total shoulder replacement is the prosthesis that is going to allow people to get back to their sport, then maybe that's something that we need to reconsider, that ratio, that benefit-risk ratio between a successful outcome for the patient versus the long-term potential for problems. So in summary, there is variation in terms of return to sport due to the pathology, the implant, the age and the surgeon, but on average, approximately 80% of people will return to their sport. It is normally 5 to 7 months post-intervention. Prior participation in the sport is important, particularly in the few months before surgery. It implies that the patient will get back to that sport. There are higher return rates with total shoulder compared to the other available options, and there's a higher return rate, which you would expect, with lower demand sports. Thank you.
Thank you very much. So these are my disclosures. When we talk about elbow arthroplasty, I think it's very important to understand that we're talking about very low numbers. 400 elbow arthroplasties performed in England last year. So the numbers are tiny compared to other implants. And when we think about our typical arthroplasty patient, this is the sort of situation we're normally dealing with, a rheumatoid arthritis with severe joint destruction. But the numbers of those cases are dropping over time because of better medical management. And what we're seeing is an increase in treatment for trauma and osteoarthritis with total elbow arthroplasty. And we're actually lagging behind the rest of Europe in that, much more rapid increases elsewhere in the world. Part of this is because the population is obviously, the demographic is getting older. We're seeing more elderly osteoporotic fragility fractures. But also, the population, as they're getting older, are also more active as they're older, and therefore they're at greater risk of falling, greater risk of sustaining trauma, which is not reconstructible, and we end up having to do a total elbow replacement. But this gives us a particular problem in terms of what we advise our patients to do, because if they've had an elbow fracture, they want to get back tomorrow to doing all the things they were doing before. When we consider the biomechanics of the elbow joint, there are lots of problems we have. So it's a very small surface area for contact, especially with it once you replace the joint. You've got short moment arms for stability, but very long moment arms for the forces that are applied through the joint. And it's often said that the elbow isn't a weight-bearing joint, but of course it is. And the forces through the hand are multiplied 7 times by the time they get to the elbow. And with heavy loading, you have about 3 times your body weight going through your elbow joint. So it is absolutely a load-bearing joint. What patient factors affect survival of our implants? Well, diagnosis is one of the most important. Rheumatoid patients do better, or their implants last better than patients post-trauma and osteoarthritis. Gender, males have a worse survival rate for their implants than females. Age, the younger the patient, the worse the shorter duration of survival for the implant. But actually, all of these are really a surrogate of one thing, which is activity level. If we look at how elbow arthroplasty started, it started off with the D prosthesis, modern elbow arthroplasty, which was a constrained hinge known as the disaster because they all fell out because it was too constrained. And what we have now in modern elbow arthroplasty is 2 types of joint replacement, linked and unlinked, and different devices are available. But most elbows that are put in the UK are of the linked variety. And then we have devices which can be put in both linked and unlinked. One of the common misconceptions is that a linked device is constrained, unlinked is unconstrained. But actually, these are 2 independent concepts. So a chain is linked, but it can be completely unconstrained. Likewise, if you take 2 cups, they are unlinked. You put them together, they are highly constrained. So the 2 terms are not interchangeable, and we need to be aware of that. Linked arthroplasty, you can change the conformity of the joint by changing the geometry of both sides of the articulation. And you can create articulations that are either constrained or relatively less constrained. But because it's linked, even if it's relatively less constrained, you will always reach a point at which the forces, the torque forces through the stems suddenly shoots up. And for some modern replacements, they're still functioning essentially as a fixed hinge, which is of concern. So how can we get around that problem? Well, potentially the solution is to move towards unlinked arthroplasty as we have in every other joint in the body. And certainly biomechanically there is a distinct advantage in varus and valgus, as your elbow would be in sports, that you will reduce the forces around the stems and therefore should reduce your implant loosening rate. Unfortunately, that's not been borne out by a historical series where we look at the results of unlinked versus linked arthroplasty. Unlinked actually has a worse outcome, but this is because of the historical designs of the joint replacements that we've been putting into patients. So if you look at how the geometry of these unlinked arthroplasties, they were either too constrained, so they were functioning essentially like a linked device, or they were too unconstrained and therefore they dislocated early and they failed. We're now reaching hopefully a happy medium. There are other surgical factors that will mean that our implants are more likely to fail. We're way behind with elbow arthroplasty, our lower limb colleagues, in terms of cement technique. We have to get better about that, about using cement restrictors, retrograde filling and all those sorts of things. And also restoring the normal anatomical axis of the joint. We've shown at Wrightington that by moving the axis of the articulation, we have an adverse effect on the functional outcomes, but it's also very likely that this will have an adverse outcome on the survival of the implant. I should just briefly mention other types of elbow arthroplasty. There's an increasing move towards distal humerus hemiarthroplasty for our trauma patients. These have the advantage of being an unlinked device, and there's only one implant that can potentially go wrong. And we don't tend to see any problems with loosening, but these are more elderly patients typically, and their demands are lower. The younger patients may end up with a radial head replacement if they have an unreconstructible radial head fracture. But again, that's a hemiarthroplasty. It's not linked, and the survival of those really depends on the design of the stem and, more importantly, how they're put in. So what's the standard of advice after arthroplasty of the elbow? Well, no more than 10 pounds of weight through the elbow at any one time, and no more than 2 to 3 pounds on a regular basis. Absolutely no evidence base for that advice that's been given to our patients. For hemiarthroplasty and radial head replacements, we don't limit their activities at all. But what do the patients actually do after they've been given that advice? Well, only 64% of patients actually remember what they were told in the first place, which is understandable. But of those who say they remember and say they've been compliant, what we actually see is that 94% of patients after elbow arthroplasty participate in moderate level activities, including golf, including swimming. And 40% participate in high demand activities, shoveling, tennis, kayaking, severely putting major forces through the elbow. And those with fractures and those for having elbow arthroplasty for non-unions are twice as likely to participate in these high-demand activities, which is possibly why they have a worse outcome for elbow arthroplasty. But it is very important for us to remember that the survival rates that we expect of 90% survival at 10 years are actually based on what the patients really do, not on what we tell them to do. So my advice to my patients is it's your elbow, look after it. The more you abuse it, the sooner it'll fail. And I think that's something that they can understand and that they can remember. But there are two activities that I give special advice about, and that's tennis and golf. And that's because not only are the forces huge, but the angular velocities are huge. And really the forces that are generated through the elbow are absolutely massive. You consider the moment arm, which is trebled by adding a golf club into your hand, and then consider when you hit the ball fat and hit the ground, you're just putting too much force through the elbow, and I just don't think it's a sensible thing to be done. So we have to remember that the patients will use their elbows as they wish. Unlinked arthroplasty is an attractive option, but it's unproven. But what we do need to do is to limit the forces and reduce the lever arms that the patients are using. Thank you very much.
Welcome everybody to this great meeting, which I hope you're all enjoying. So my remit is to talk about sport after hip replacement, when not to do it, no disclosures. So just a few words about the development of hip replacement. So Sir John Charnley developed hip replacements, and a lot of the things that he developed in the early 1960s are still materials and techniques and designs that we use today. But when Charnley started out, he was really suggesting that this was something as a salvage procedure. This was surgery that was reserved for really elderly, disabled patients. But you can see from this chart that the peak incidence of osteoarthritis is about 70, but of course younger people are getting arthritis, and there has been a move towards younger and younger patients getting hip replacement. So this is a chart from USA data between 2000 and 2010, a 3 times increase in the number of patients under 65 having hip replacements, and UK data is similar. And of course, many of these patients will remain active and want to remain active. So what can we do after hip replacements? I mean, widely recognised hip replacements are brilliant for pain relief, and almost all patients having a new hip have got great relief of pain. But there's good evidence, actually, that no matter how good you are at doing hip replacement, patients will lose muscle bulk and lose muscle strength around the hip. And actually, although anecdotally it seems that everybody is much better and does a lot more, there's actually little evidence there's much functional improvement after surgery. So people don't actually get back to doing more than they did before. And of course, there's always a concern, as other speakers have mentioned, of a link between higher activity levels and implant failure. And I'm going to explore whether such a link really exists. But of course, baby boomers like me, young active men, want to get back to doing all this, and marketing has become heavily involved, so lots of different implants have been heavily marketed as the next thing in hip replacement, and patients do want to get back to doing these sporting activities. So let's explore if it's sensible and what they can and can't do. And 35% of hip replacement patients are doing sport preoperatively, and a desire to return to their sports is a major expectation. So are we achieving this? Look at the literature. So this is a paper which basically looked at activity after hip and knee arthroplasty. And although patients were active and wanted to do sports, actually half of them stopped doing their sport. And that was partly based on the advice of the surgeon. I'll look a bit more about surgeons' attitudes, but also fear and anxiety about damaging the joint, a precaution to go easy on the artificial joint. So patients, for whatever reason, didn't get back to doing perhaps all the things they wanted to do. And what about the surgeons? So big data is out there, and people know what our revision rates are, and the government are keen to publish our failure rates. So obviously any surgeon is keen to avoid a complication in our patients. And of course, high revision rates, high failure rate doesn't look bad in our data. So what about surgeons' attitudes to sport? So this is North America, and a survey of 614 North American hip surgeons. And we've seen a similar thing with the shoulder, but basically it was broken down into what surgeons would allow, and again, allowed with experience, what does that mean to the sort of activities that you could do if you, I guess, were good at it, so skiing and higher impact, but really a general feeling that people wouldn't allow higher impact things, and particularly contact sports. Of course, there's no real strong scientific evidence to support this. So what about in the UK? So this is a survey of Hip Society members, and so the sort of timescale under which we would let patients to return to sport. All the hip surgeons indicated that they would allow patients to go back to low impact activities, but significant caution with high impact activities. So a reluctance amongst even experienced hip surgeons to let patients return to high impact sports. So what can we do to improve hip function? I mean, it's very good, but can we make it better? Marc's going to talk a bit more about surgical approaches. I'll say a few words about implant design, so how we fix the things, what about the bearings. And perhaps the most important thing is putting the biomechanics right. If you put the hip thing in the right place and get the biomechanics of the hip correct, then that's likely to optimize muscle function. and what we can do to improve implant position. Again, if we get the implant position right, it's more likely to work well. Fixation, and you can get orthopedic surgeons talking all day about cement and not cement, but I mean, basically my philosophy would be that an uncemented acetabular component would certainly be the way to go for an active person. Really, with a femoral component, cemented, uncemented components both work, and there are pros and cons of doing both. The bearing is probably the weak link, and this chart basically shows you what the problem is. So where debris from the implant is ingested by the macrophages, which elicits an inflammatory response, which causes bone damage and loosening of the implant. So there's concern if you've got increased activity, will you increase the wear by increased loading and more implant cycles? So we're really keen to do what we can to reduce wear. So the bearings are an important part of that. So the sort of workhorse has been polyethylene, and that's what John Charnley developed. But moving on to ceramics and hard-on-hard bearings, ceramic on ceramic or metal on metal, both of which have much lower wear rates, and the hope that reducing the wear rate will increase the survivorship of the hip replacement. So what about the sportsman's hip? So this was marketed very strongly about 10, 15 years ago, and these metal bearings do have a very low wear rate, but there's never been any great evidence there's much functional benefit, and failures relate to metal wear debris. They're bone preserving, and there may be a place for bone preservation in the more active patient where you know you're going to be going back later on and doing something else. Getting things in the right place, so people come up with custom implants, but I think Marc's going to touch on that. There's no evidence that custom implants have improved function or results. Similarly with patient-specific instrumentation. Robotic-assisted surgery, robots have come and gone, and guided surgery. And we may be reaching the stage where robotic surgery really is going to help us here. So we're not very good at putting components in. This chart, this box here shows you the ideal position of an acetabular component, and these blue dots show you where experienced hip surgeons actually put them. But this Mako robot basically allows preoperative planning, and then the robot guides the placement, and the data would suggest that you can actually get almost all the dots inside that box using this, and we now have a Mako robot which we're going to start using at the Cromwell. So that's going to help. So I hope. Potential complications. So I've mentioned accelerated wear and early loosening. What's the evidence on that? Dislocation, that's a disaster, and we all want to avoid that, and periprosthetic fractures. So does impact sport affect how long hip replacements last? This is a paper from 2012 comparing low and high activity groups, and they found that the wear rate was double in the high activity group, and the 15-year revision rate was also higher in the high activity group, suggesting that perhaps there was a link between high activity, wear and failure. But there were better functional scores in the high activity group, which I guess you'd expect. Again, this is another paper, quite an old paper, comparing skiers and downhill skiing. 8 times the body weight will go through the hip, compared skiing and non-skiing groups. So again, they found greater wear in the non-skiing, greater wear in the skiing group, but there was no difference in revision rate. I would point out that these papers are both with older bearings, not much ceramic on ceramic, and older polyethylene, and it's likely, I think, with modern bearings that those results will be better. Dislocation, so historically quite a high incidence of dislocation, and quite a high proportion of revisions are done for recurrent dislocation. And of course, there are concerns that being more active will increase the risk, but actually the evidence would suggest that dislocation is much more often related to low-impact activities. So putting on your shoes, getting in out of the bath, etc., is actually far more likely to cause a dislocation than sport. And Olivier's paper found that there was actually no difference between dislocation rates between the high and low-activity groups. So it probably isn't an important factor. Intraoperative fracture is a potential risk. Putting a stem down the femur weakens the bone. So that's called stress shielding, and that must make it more liable to fracture. So high-impact sports must have a risk of causing a fracture. But actually, the evidence linking fracture to sport is not very strong. Fracture, of course, is an intrinsic risk with any dangerous sport, and the main issue for us is it can pose a major reconstructive challenge. So, in summary then, I think our modern hip replacements, we can restore high levels of function, and of course our patients do want to return to sport. There's actually not a great deal of evidence that high-impact sport increases the complication rate, but they may wear their hips out more quickly and may require revision more often. we remain as surgeons cautious about recommending return to sports, and dangerous sports are dangerous and have intrinsic risks, and it can make things more difficult for us as surgeons. So I think my sort of philosophy would be that preoperative counselling is important in patient expectations, and this is a quality of life and perhaps rather than a lifestyle operation. I think we should use implants which have got good evidence of long-term function, putting them in very accurately, potentially with robots, a safe, predictable surgical approach. There may be a role for the sportsman's hip in very active patients where there may be a revision, but I think the data is not there on that really. So thank you very much.
Morning, and thanks very much. Inevitably, when you have two hip surgeons talking about a fairly similar subject, there will be some overlap despite our best efforts. So I hope this will serve to reinforce in some places that perhaps we will have differing perspectives. In my own practice, I am a hip arthroscopist as well as a hip arthroplasty surgeon. That often means that I get a disproportionately young group of patients who have degenerate joint disease. So the majority of my hip replacements are actually under 50. Those under 30 are fairly common. I do some teenage hip replacements, including some of those who are still at school. They're going to represent a group that are potentially going to want to do far more with their hip replacements. And also, as we've heard, our older patients, even post-retirement, are wanting to actively participate in sport, and they're not happy anymore just being out of pain. The point to stress, hip preservation surgery is not an operation for young people with arthritis. It doesn't work. So you have a population where you're going to have to be considering arthroplasty. Often, by the time you actually see your patients, it's already predetermined whether or not they're going to do sport afterwards. Many studies, this is a review not only of hip replacements, but also of knee replacements. And again, as has been stressed with other areas, that pre-op sporting activity determines probably more than anything else whether or not you're going to do it afterwards. Age and BMI, yes. Are they independent to the pre-op sporting activity? You can question. But certainly as surgeons, there are things that we can do, thinking about our approaches, what type of implants, types of bearings and restoration of anatomy. We've got to think about how we rehab our patients, and clearly not only the surgeon and the physiotherapist will have an influence on that, but also the patient themselves. And I tend to, as others do, think about types of sport being those that are low impact, those that are high impact, and those that, with or without a hip replacement, have an intrinsic risk of fracture. The fears that patients come to you with are often in different orders of what we might expect. Fear of dislocation tends to be right up the top in my experience, as well as fractures, and still that fear, am I going to wear out my implant if I go back to sport? Am I allowed? And that is obviously fanned by surgeon paranoia. But in fact, there's good evidence that it's not pain and fatigue at all. They can do these things, and the main reasons are they're not getting back to do it are their own fears and the fears of their surgeons. Just going to quote the paper that Simon already quoted, and really want to stress my perspective on that the bearing wear being an issue is really with polythene. It's not with ceramics that I tend to use. That's not been shown. Restoration of anatomy, modular implants allow us to restore patients' anatomy in the vast majority of patients. Personally, I'm quite concerned about some of the use of bespoke implants, perhaps as a marketing tool. Have a discussion with the patients, but intrinsically, every time you use a bespoke implant, it is an untried, untested implant. And I think that the use of those is very niche. Certainly, personally, the last person I put a bespoke implant in was because he was 3'9" tall, as well as having funny anatomy off the scale. We've talked a lot about loading, and there's a lot described about the load patterns that we put through our hips, the potential how many times body weight we're doing. And it's interesting, we've heard about skiing being 8 times normal body weight, lifting heavy weights above the head is 9 times, but that's actually exactly the same as a minor stumble that takes a moment or two to regain your balance. So perhaps we need to think about what, in fact, we're doing in normal day-to-day activity, and is it that different? Femoral blaze is an interesting concept. My radiology colleagues looked at a number of implants. It's the Cry stem, which is a fully coated implant. It's the most popular uncemented stem in the UK. And certainly there appears to be a subset of very active patients who during the first few months will get thigh pain when they're active and have this very high activity on SPECT-CT around their implants. It's very different to the problem that some of those diaphyseal potential fitting implants have later on with proximal loosening and distal fix that's been described. It is self-limiting, but it does make you look at the implants and wonder whether the types of coating, stress shielding are really more of an issue. And certainly I wouldn't favour these type of implants in younger active patients. Approaches. I think in my mind this is perhaps where things may change. We've really gone through the approaches, transgluteal approaches. Hacking through your abductors probably isn't a great idea, and most of us have moved away from that. We've gone through posterior approaches, realizing fixing the posterior structures is important for stability, and move through just a small incision but damaging everything inside to thinking about actually what we cut, and now perhaps thinking about not just what we actually cut, but how we maneuver the hip around. You know, you can keep the piriformis intact, but if you maneuver the hip around 95 degrees and stretch it to 2.5 times its length, will it actually still have its normal function and proprioception? And I think perhaps this is the direction that we may be moving in. Rehab. It's got to be personalised. Traditional habits certainly do die hard, and we should be there to challenge them. And I think one of the best examples of that is traditional dislocation precautions. They never had any scientific basis. At Guy's, we took a decision as a unit many years ago to take them away completely. I think we were the first NHS trust to do so. But 8 years on, it's quite hard to break those habits still. And I think that's the same with all other traditional rehab precautions. It will take a long, long time to change perceptions. So we've heard already, low impact, we encourage it, we want people to do it, we're happy to do it, it's not controversial. The high impact exercise, there is concern, but it's concern based on perception rather than actually the reality. And fracture risk, you're not more likely to fracture your femur if you do fracture risk activities, but I think you probably have to accept that the implications may be a lot more serious. Just a couple of examples, really. You know, how far can you push things? This is a patient who I saw recently for their 5-year follow-up, who I first met very upset a few weeks before the London Olympics, where she'd been selected to run a leg of the torch relay. She is a personal trainer, very active, keen runner, and had a very rapidly progressing avascular necrosis. So she had my fairly standard hip replacement, was able to run the torch relay at about 8 weeks, and when I saw her at a year, came along with a London Marathon finisher's medal. Now 5 years, running 10 marathons plus a year, no adverse clinical or radiographic features. What are the series on these types of patients really pushing it? Well, there isn't really the data out there. All I really wanted to say about that is, did I do anything special? No, did exactly the same as I always do. It just highlights the fact that your patient factors are the most important. And this was a dream, really. Someone who's very fit, very active, goes downhill very quickly, isn't particularly deconditioned, has a sensible, pragmatic attitude to strengthen conditioning and return to activity in a sensible way. Another example, someone in their 30s, bit younger, dysplasia with arthritis, was actually going back to running after maternity leave with twins, so it actually had a fair amount of time out of running, and had one side done, the most symptomatic side, and by 6 weeks was feeling great and went out running, because that's what she did. Fantastic. But then lots and lots of soft tissue problems, psoas irritability, injections, taking an awful long time to rein it in. Had the other side done, took a more sensible approach, and did get back to doing top-end things, but really just a cautionary tale. You've got to have a sensible approach. This is training, with or without a hip replacement. You can't suddenly go back to doing something you haven't been doing for a long while. All sorts of sports. Skiing is a very, very commonly asked one. And you've got to take the patient on their own merits. A patient, a Scandinavian Swiss patient, they've been skiing since they can walk. They're very good at it. Even if they're old, a bit parotic, you probably don't need to worry. The average Brit is an appalling skier. Is somebody who's been skiing twice and uses a mechanism to go from lunch to the evening refreshments actually really a skier. I'm not saying they shouldn't ski, but perhaps you need to reevaluate why and how they're doing things. The barefoot water skier was probably the only one that really, really scared me. Going back to barefoot water skiing, I didn't want to see it. I didn't want to know they were doing it. I'd asked them to send a video if they did. They went back to doing it on skis, but not barefoot, and I'm still waiting for the video. There's a few others there, but I'm running out of time. So my personal approach, uncemented ceramic on ceramic, proximally coated, mini posterior approach, but that may change. I very rarely use bespoke implants, but always templates. No dislocation precautions, crutches just to get back to a normal gait pattern, and in essence, a progressive return based on their activity and fitness. Counsel them about fracture risks, but remember, high impact exercise is a bonus after hip replacement, not a primary expectation and not the main reason for doing it. I'm out of time there. Thank you.
Thanks, David. No disclosures for you. As I was preparing this talk, I thought I would try to scrutinise the literature with regard to these sort of questions, which I think patients may be interested in, and as surgeons we may be interested in as well. First of all, what do we recommend as a body of surgeons to our patients going back to sport after knee replacement? Does knee replacement help patients return to sport? And if so, which particular sports are possible? What are the effects of sport on the prosthetic joint in terms of biomechanics and also in terms of revision rates? And might sport in fact be beneficial? So first of all, what do we recommend? Some of the guys have already covered some of this, but it's really based on surgeon opinion. This is from the Knee Society website. We're in the patient information section. And as you can see, rather similar to the hip advice, there are recommended activities and not recommended activities and something in the middle, really based on high, low or middle intensity sport. Very similar in the surgeon survey-based studies, either postal questionnaires or studies taken at conferences. And you'll see here similar sort of levels of intensity of activity, and it's really pretty much common sense stuff. I'll just bring your attention to golf, cycling and tennis because I got some specific papers on this later in the talk. So moving on now to whether total knee replacement actually helps patients get back to sport. Well, it does seem to improve your cardiovascular fitness. This is a study where 19 patients who were having knee replacement were compared with a control group of patients who underwent medical treatment for their osteoarthritis of the knee. And the study group did seem to have, on various functional assessments, an improved oxygen uptake after knee replacement, and the control group didn't seem to have a similar sort of benefit. So it does seem to improve your overall cardiovascular fitness. What about returning to sport specifically? Well, this paper from Germany, I think Simon has mentioned this because it does talk about hip replacements as well, does show a reduction in the proportion of patients able to undertake regular sport 5 years after knee replacement. They managed to see 79% of their patients for follow-up at an average of 5 years. And you'll see the proportion undertaking sport in the total knee replacement group reduced by, 8% compared to hip replacement, which increased by 16%. The proportion doing sport for 2 or more hours per week again reduced in the knee replacement group, but increased in the hip replacement group. This paper here looked at the proportion of patients returning to participation in sport and the number of sports undertaken, slightly shorter follow-up, but we do see in the second line 55 patients out of the 76 total knee replacement patients were participating in sport pre-op, only 35 post-op. And if you compare this to unis, the return to sport rates were 63% for the totals and 96% for the unis. This study from Sweden looked at the patient's preoperative expectations and compared them to their postoperative ability. prospective study looking at patients for 5 years. 41% expected to be able to return to golf or dance, but only 14% were able to do so. This paper here looked at, in fact, we've got two papers here, the top one from Merv Cross's group in Sydney and the bottom one from Professors Blom and Learmonth in Bristol. And they show broadly similar return to sport rates in the 60s%. And this is one of the examples of slightly conflicting evidence from the literature. The Blom and Learmonth paper showed that there was no difference between hip, total knee, unicondylar and patellar resurfacing. There are some improved return to sport rates in the literature. This from John Noel Arginson's group in Marseille, which shows over 80% return to sport in a high flexion design, but it's a single surgeon series. So moving on now to whether sport is possible to which specific sports are possible. And this paper here from Adelaide looked at particular types of sport that patients were able to undertake, and they firstly said that there was increased participation in certain types of sport, aquarobics and exercise walking, and some patients took this up for the first time after their knee replacement, perhaps stimulated by some of the physiotherapy that they'd had, hydrotherapy and walking as part of their rehab. But golf, there was a significant fall in participation, and 10 of the 19 golfers actually gave up golf after their total knee replacement. Another paper looking specifically at golf. I'm not sure that my patients would like to hear that their golf handicap might go up by 4.6. Some of the bandits out there might do so, but they're also going to hit the drives for shorter distances. Quite a high proportion will have to use buggies, and a significant proportion will have pain during or after sport, with golfers with left total knees seeming to have more trouble with golfers with right total knees, and that will be looked at in more detail in the biomechanics studies. This survey looking at 151 golfers showed that the majority do return to golf, but again, a high proportion using buggies, and only 14% walked the course after their knee replacement, where 28% of them had done preoperatively. Tennis, in this group of patients identified in cooperation with the American Lawn Tennis Association, these guys were high-level tennis players and were able to get back to tennis 3 times a week, including singles tennis, despite the advice not to do so. So it's quite interesting. We're advising patients not to go back to singles tennis, but some of them seem to be able to do so, and we're advising patients to go back to golf, and some don't seem to be able to do so. And this might help us work out why. This is a biomechanical study from, can't remember, but there are instrumented tibial components put in these patients, which enabled the studiers to look at the forces and the motions generated in golf swings. And they found very high forces, especially in the leading knee, in the downswing, and also in the follow-through. And you can imagine why that would happen. This looks a bit like Luke Donald to me, and you can see in his leading knee there that he's going to generate quite a lot of force, rotational force. And they compared golf to a number of other sports and found that it was particularly high forces in golf. Another study looking at this time at continuous fluoroscopic assessment kinematically of patients through golf swing and through a cycling movement, and found that there were excessive internal and external rotation forces in the golf swing compared to cycling. This is more of a clinical and radiographic assessment. Patients who were undertaking high-impact activity, jogging, downhill skiing, basketball, etc. And they found that the vast majority of their patients were able to return to these particular sports, but you'll see that golf isn't in there. What about the effects on revision rates? Well, according to this paper and the next paper, there doesn't seem to be an increased revision rate. This was a very carefully designed study with logistic regression analysis, age, sex, and number of total knee replacement matched groups, 17 female and 19 male pairs, and they found that increasing sporting activity in the preceding 15 years did not have an association with increased revision rates. Borne out again in this paper from Maryland, which shows no increased risk of revision if you compare a high activity versus a low activity group. So slightly conflicting evidence on which sports to undergo, and some of these things actually go against what we would suggest. One slide now on whether sport might be beneficial. Ergometer cycling has been studied in this particular piece of work. It's a randomized controlled trial. Half of the patients were randomized to go through a ergometer cycling type rehab. Half of the patients went through standard rehab. There were knees and hips in the group. And on the basis of WOMAC scores, at certain time points post-operatively, there was no benefit in the total knee replacement group compared to the hip replacement group, which did seem to have a benefit. So in summary, we seem to have a return to sports rate of around 60%. It's somewhere between 54 and 90% in the literature. Golf does seem to put high stresses on knee replacements, and that seems to be borne out not only in the ability to return to sport, but also in the biomechanical studies. But revision rates, based on somewhat scanty data out there, seems to be no higher.
I preface my remarks by saying it's not a black and white subject. In fact, it's murky and extremely grey, and there is very, very little data. I have no disclosures other than the fact that I'm a part of the problem. I'm over 50. I exercise a fair amount. I ski for about 6 weeks a year doing ski mountaineering. I can't run anymore. My knees and my ankles hurt. I bought a bike, it's even carbon, and I confess to wearing Lycra. So I'm my disaster patient, because I want to carry on doing all these things, don't I? Our problem is we've got this huge ageing active population. I'm ignoring the subgroup that are ageing, obese, and inactive. I'm concentrating on the ageing and active. We have massive expectation. I hope I won't listen to all that lovely marketing from Zimmer and everybody else showing their lovely partial knee replacement with you running, jumping, playing squash till you're 99. We worry about implant failure. We worry about longevity. And I'm specifically concerned about knee replacement post-osteotomy. We discussed this yesterday afternoon, and we have big concerns about soft tissue balancing. My other area of concern is the conversion from a unicompartmental knee replacement to a total knee. This is not benign, and it's the same result as performing a total knee to revision total knee. And there's some great work on that from Parat, who publishes about everything. Actually, I'm very impressed with his publication rate. So that's my talk. There is no consensus. There is no hard evidence in partial knee replacement. There are, however, some things we do know, and that the best study is a systematic review, and they looked at about 2,800 unicompartmental knee arthroplasties. They found that the most common activity after the surgery was hiking, cycling, and swimming. They found that overall sport involvement decreased by between 2 and 9%. And the number of specific sports undertaken by an individual also decreased. The overall participation in sport was lower than the pre-arthritic levels. But the important thing was the increase in low-impact activity, which has been alluded to earlier. There was also a simultaneous decrease in high impact, which has multiple factors, which Marc alluded to. What do we know? Well, the paper that Ian spoke about earlier actually won an award. It was a fantastic paper using the instrumented prostheses and making people do normal activities. We know with a static bike there's a low tibial force. We know with jogging and with tennis we produce high force with peak loads. And of course, the thing that did surprise everybody a little bit was golf. And it's always the leading leg, so it's left or right, depending on whether you're left or right-handed, of course. What do we know? Well, high impact can produce wear. And we know that wear is dependent on load, the number of steps or cycles, and the materials used. We know that endurance activity for fitness tends to be repetitive and fairly high intensity. So we know that it's a good idea to encourage our patients to undertake exercise with low joint load. We know that recreational activities tend to be slightly lower intensity, so perhaps that's the time when you can have higher impact. There are some suspicions about jogging and hiking and delamination of the poly that we use in partial knee replacement and indeed total knee replacement. And to be fair, the plastics have probably changed somewhat since then. We've seen what surgeons say. You've seen the same. I think we're all saying the same thing here. We're even quoting the same papers. But the best line is the fact that there is no true scientific basis for our advice. We have our fears and concerns, but we don't have the evidence in front of us. The fascinating thing is that the higher the volume the surgeon, the less likely they are to restrict the patient. So the more you do, probably the more confident you are about it. And even that Knee Society guideline, it's very, very wishy-washy, actually. So in consensus, they'd say, we recommend that you go swimming, you do your aqua aerobics. Cross-country skiing is fabulous, or Nordic track, cycling, stationary bike. We don't mean mountain biking down a mountain. Golf, yes, with the caveats we've already alluded to. Dancing, I did notice somebody referred to pole dancing in one of the talks, I'm not sure about that. Sedentary occupations, including desk work. Most people permit hiking, doubles tennis, and they mean that to be gentle rather than super competitive. And gentle downhill skiing, and I'll come back onto that. Light occupations are fine. The majority of surgeons don't recommend jogging, running, high-impact activity, and things like squash, which require aggressive twisting or pivoting. Most people wouldn't recommend contact sports, and certainly heavy jobs. But all of the above are recommended by lots of people, and especially people doing lots of unicontinental. So I looked at skiing. It's something dear to my heart. If you look at the Swiss population, in their unis, about 22% return to downhill skiing. And that's not just tootling down a green run, they'll actually ski properly. At ESCA in Geneva, the FIS meeting in ESCA, which is the governing body for skiing, advised against skiing in total knee replacement. There were multiple papers, and one of them showed, again, it was an instrumented tibia, that skiing down a blue run was the same impact load as trying to sprint with your joint replacement. We know the type of skiing is very important, because if you're skiing on a lovely, soft powder, shallow slope, the load on your knee is relatively minimal. If you try and attack a very steep, icy, mogul-filled nightmare, I'm afraid you are going to overload your knee and have huge peak stresses. You may also overload your mentality for skiing afterwards as well. I think we should be encouraging ski touring and Langlauf, or cross-country skiing. They're fantastic for cardio. We can keep our patients in the mountains, and all they have to do is get to the top and take the lift back down again. And of course, we've already talked about the risk of fracture, which is ever present with skiing, whether you've got an implant or not. We know the results for lucency and radiographic loosening for joint replacement are surprisingly not there. There aren't any, and the studies are out. There are 4, 6, and 7-year-old studies showing no significant changes in people who ski a lot. The bit about experience is obviously people who are very previously competent, and certainly our Swiss neighbours are very, very good at skiing. They've done it since they're 2, as you say. But there are lots of British people who ski a lot, and they're very technically satisfactory. If you're going to do it, they need to address the whole limb biomechanics. And I would suggest the option of the Ski Mojo for some of your older patients, who are those who are contemplating joint replacement for skiing, because that offloads and is a spring. Special award to Mr. Lavelle for the trousers. Golf. The paper that was alluded to earlier about walking the course, only 14%. I've got to say, that is an American paper. And in America, they are very used to using buggies. In the UK, it's a different ethos. I hope it still remains, and people will walk the course. And I think you'll find for unis, the ability to walk around the course will be far better. Most are back to enjoyment, and 81% players more often, which is good. We've talked about excessive rotation and the torsional force, somebody who actually will follow through. Well, actually, to my mind, there's a place for our unicompartmental arthroplasty, especially with a mobile bearing. There'll be less stresses across our implant. With running and jogging, can I run? Yes, you can, but, said Kevin Stone, you need lower peak forces with a shorter stride. You need mid-foot landing, soft surfaces, and again, pre-existing biomechanical issues must be addressed. What did Freddie Fu say? Well, he said, the occasional low-mileage run on soft ground is safe with modern implants. But you've got to ask yourself, are you willing to undergo further surgery in the future to continue to enjoy your high-impact activity? I think that's a very balanced approach. I think you should all go and look at this website. This guy is very famous in the running world. He had 5 years out with osteoarthritis, not running at all. He had a uni in New Zealand, got back to running, and then won the 5K and 10K Masters US Championships for age group. And he's continuing to run to this day, having had the other knee as well now. Our goal is to get our patients back. And this is my very good friend. He skis with me every year, and he's 2 years post-bilateral hip replacement, enjoying every second. He has increased wear, I'm sure. In summary, unicompartmental knee replacement allows increased activity levels. There's hard evidence for that. There is minimal evidence with regard to high-impact activity. We still have this active aging population with high demand, and we need to be vigilant with those people. We still really need a biological solution. The current trend is for increased activity, and there's no evidence base to discourage this, but we have to keep an eye on it. Sports experience, i.e. people going back to sports they love and can understand, are very relevant, and directed rehabilitation and addressing underlying biomechanical issues are absolutely crucial to minimize risk. Thank you very much.
Thank you. So finally, we end up at the lower end of the body, or specifically the ankle and the big toe. And we don't have any meta-analyses or systematic reviews to rely on. So when you look through the literature with a fairly forensic eye, a number of problems crop up. First of all, the use of the word sport. Now, sport is really defined as exercise activity in a competitive environment governed by a system of rules. And often the word sport is used in the literature to mean something else. So we have to sort of be careful what we're looking at. There's also the issue that the previous speakers have talked about whether you can get back to sport is one thing, but should you get back to sport is another question perhaps. Also, we're frustrated by the fact that most outcome measures which we use to measure the success or failure of implants don't include specific questions about sport. And then there's obviously the patient population you're looking at. Are you looking at a sports person, or are you looking at a fairly sedentary individual? So that's the problem we have. The other problem is that ankle replacement, you can see here, it is much less commonly performed, over 100 times rarer, in fact, in the National Joint Registry figures than hips or knees. The other thing you'll see from this slide is the average age is about late 60s, which is roughly the same as hip and knee replacement patients. But the average age of a patient presenting with end-stage arthritis is late 50s. And why is that? Because we have this trick up our sleeves of ankle arthrodesis. It's a lovely picture of a video who's had both of her ankles fused by myself and has a normal gait. So we have this procedure which you wouldn't dream of performing in a hip or a knee or even a shoulder or an elbow and expecting a reasonable outcome, but we do get reasonable outcomes. So, looking at ankle fusions, this is hot off the press, a recent paper which looks at ankle fusions and return to sport, and about 70% get back to sport. The word sport being used loosely, as I said. But if you look a little bit more closely, there are some high-impact activities included in there. So these patients are able to do relatively sporty activities following such a major operation. And we've got the same thing in the big toe. We can fuse the big toe as well. So we're really looking at joint arthroplasty through the prism of comparison against fusions. And this paper, again, shows quite a decent rate of return to sport. There's 75% here returning to jogging. So what about actually answering the question that I've been asked? Well, we've only got 3 papers which look specifically at return to sport after ankle replacement. Unfortunately, they're all papers reporting the outcome of a prosthesis designed by the author of the paper. So there's an element of bias which you have to take into account. They've all got reasonable numbers, so over 100 or so implants in each group. And what they find is that there's an increased participation in sport post-arthroplasty, around about 60%, but low-impact sports only. Only one paper goes as far as to give some guidelines, which along the lines that you've heard with hip and knee replacement, and not recommended are really high-impact sports. So, for example, singles tennis, not recommended, but allowed with experience or caution would be doubles tennis, and so on. There's only one comparative paper of ankle replacement versus arthrodesis, and that compares 21 fusions against 20 ankle replacements. And what you find is there's a reasonable return to sport in both groups, about 75%. But again, it's low impact. Interestingly, skiing in the context of ankle replacement is a much lower impact, lower torque, lower risk sport than it is, for example, with knees, because of course you're encased in a ski boot. So that's ankles. And what about the big toe? Well, there's an added problem here in that what do we mean by arthroplasty? Because there are arthroplasties and there are arthroplasties. So there's an excision arthroplasty called a Keller's, which is more or less a historical operation, and really is only indicated in relatively low demand patients, but has a high patient satisfaction rate. Slightly more interesting, perhaps, is a modification of the excision arthroplasty, where slightly less bone is taken away, and then a tissue such as a tendon or a joint capsule ligament is interposed between the bone ends. And this is a nice study comparing 10 of those patients against 10 fusions, and had similar outcomes in terms of return to activities. So there may be something in this for the future. Silastic implants, again, historically more important than currently, more in the lower demand age group, but still has a role in today's practice. The problem with these is that you're unlikely to get back to any kind of sport, and revision, when it all loosens, is relatively challenging in terms of the amount of bone loss and the big holes that are left behind. But we do have total joint replacements in the big toe, and this is a series reporting return to sport. It's the only one that comments on sport, so it's very short-term follow-up only, and apparently very successful in the short term, 87% returning to, again, low-impact sports. But if you look at the longer-term data, they're relatively disastrous. So big toe joint replacements or total joint replacements are not good in the long run. They tend to loosen, they tend to sort of take away a fair amount of bone as they loosen, and again, they're very difficult to revise. So nowadays, when we talk about big toe replacements, we're really talking about hemiarthroplasties, so that's where the interest lies. And the original ones were proximal phalangeal replacements, and they're still implanted by some surgeons. Most of us have given up on those because, again, they tend to loosen and take with them a lot of bone. So the emphasis now is on first MTP metatarsal head resurfacing hemiarthroplasties. And there's only one paper, again, we're quite limited in our literature in this regard, but shows only a slight limit to recreation. And certainly these patients do get quite good range of motion in their joints. There's relatively little bone resected at the time of the operation, but they'll still have decent sized stems. So we don't know what's going to happen with these as they loosen, but they're probably not going to be as easy to revise to a fusion as the authors are claiming. There's quite a lot of excitement about this implant at the moment. It's the Cartiva implant. So it's a synthetic cartilage. It's actually a wine gum made of polyvinyl alcohol. And it looks just like a wine gum, and you burr out a little hole in the metatarsal head and you slot it in. It's a very easy operation. You combine it with taking the bony spurs off. And we actually have level 1 evidence for this. There was an RCT, randomized controlled trial, which compared this to arthrodesis of the big toe at 2 years and found that it was comparable in terms of outcomes. Again, we don't know much about return to sport. I have performed several of these, and I have some patients who've gone back to running afterwards. The problem with the implant is going to be subsidence. You just drill a little hole in here, and obviously the more impact and motion you put through that, the more it's likely to subside into the metatarsal head. So this is my patient who's is happier with her metallic right big toe operation and less happy with her Cartiva operation. But I don't mind too much because I could revise that to a fusion very easily if I have to further down the line, but that will be a little bit more tricky. So to summarise, impact sport now probably is brewing up problems for later on in terms of ankle and big toe arthroplasty. So I'm much less optimistic than certainly my hip surgical colleagues have been. And the reason is partly that revisions of ankle replacements, certainly, and big toe replacements to fusions are quite challenging procedures. So we don't want to store up too much trouble. These are younger patients as well, so if they're presenting in their late 50s, on average, we've got some very young patients among those groups. And we've got the option of arthrodesis. At the end of the day, we're much happier performing a fusion, particularly if they want to get back to sports, and they can get back to high-impact sports. They can, but should they? So just to finish, this is a salutary tale of a patient of mine who had an ankle fusion in her 20s following trauma, and she continued to compete in triathlon and actually represented her country, South Africa, at skydiving, and then presented 20 years later with severe arthritis and instability of the subtalar joint. And so has ended up with this situation in her mid to late 40s, which is not a good situation to be in. So yes, we can fuse joints, but yes, we have pressures on the adjacent joints to worry about as well. Thank you.
I just got an opening question while we get the mics ready to go. I was just wondering, a general opening question for the panel, whether you recommend different implants or different types of fixation for people who are wanting to undergo sports after. I'm specifically thinking about shoulders in terms of constraint and also hips in terms of femoral fixation and thigh pain.
Okay, well in shoulders we've got those different implants between a hemiarthroplasty total and then the reverse, and that reflects the pathology, as I've said in the talks, that may affect your advice subsequently. In terms of cement versus uncemented prostheses, then there is a move very much towards uncemented prostheses within the shoulder. The constraints really relate to the original presenting pathology. So if you've got a cuff deficient shoulder, you're probably going to put in a reverse shoulder replacement. Obviously, our concern is that in that age group without a functioning cuff is more likely to fail, and I think that's borne out with some of the evidence that we had. But cemented versus uncemented, definitely a drive towards uncemented within shoulder prostheses. And of those things that I showed there, some of the resurfacing or short stems, they're designed that they can be converted at a later date into a reverse replacement. So you're almost putting in your prosthesis for the revision procedure to make it easier in the longer outcome.
From the hip perspective, I have to say I tend to use uncemented implants in pretty much everybody anyway. Much to
no thigh pain in sports people?
No, sorry?
Thigh pain in sports
Well, as I say, those early fully coated HA, so I tend to use proximally coated, more metaphysical loading, anatomical prosthesis. I think ceramic on ceramic really addresses the wear issue in my mind.
I would largely agree with Marc. I mean, certainly I think the bearing is more important than the fixation. I actually favour a cemented femoral component because I think I've got more control over where I can put it, depth of insertion and diversion, but I think both work, and it's possible with robotic surgery and guided surgery actually we can put both types of components in the same place. I don't think there's any evidence that cement or uncemented has got any advantage in anywhere really in terms of function.
For the elbow, definitely unlinked arthroplasty for the younger patients. At Wrightington, 80% of our elbow arthroplasties are unlinked anyway because we believe in the concept. But for those higher demand patients, you significantly reduce, as I was talking about earlier, that you reduce those torques through the stems by doing it unlinked because the soft tissues absorb the forces. And I have a patient, he's not an athlete, but he's a 50-year-old grave digger who comes back and sees me every year and continues to dig graves with his total elbow replacement, continues to carry caskets full of bodies. And, you know, I shudder to every time he walks into my clinic, but his x-rays show no change, no loosening. I'm sure if I'd linked him, it would have been out 3 years ago.
I suppose for Andrew and Callum, the question would be uni versus total and fusion versus arthroplasty.
All the ankle and big toe arthroplasties are uncemented, so that's easy. But yeah, I think, as I alluded to, it's fusion really. So really in the age group who are expecting to get back to sport, proper sport, we would definitely favour fusion. I don't really know anybody who would disagree with that.
I think the real debate for us is more osteotomy versus uni. I think that's where it's at, and we talked about that yesterday.
Yeah.
In terms of implant, whether it's mobile bearing or fixed, there's no evidence data for difference. For patient specifics, no evidence data for difference. Cemented v uncemented, no evidence data for difference. So take your pick, but put it in properly.
Thank you for sharing your thoughts and also my golfing attire with the group. Just one point about the knee replacements, obviously a particular personal view, is when you see those figures, it's disappointing. You sit in your clinic and you feel most of your patients who come along wanting to get back to golf will get back to playing golf, and it's surprising when you see those numbers. Do you think that part of that is that people get out of the habit and that it's not so much that they can't, it's that they just don't get back into it? And in the literature you've looked at, is there evidence to see why people aren't going back?
I think there's a lot of evidence in the literature that a lot of our exercise behaviour is truly, we are creatures of habit, and if we get out at that point, we just don't do it anymore. There are various other sort of fiscal reasons in the UK for golf, so it's not really a mass access sport. People stop doing it, they stop being members of clubs, they stop paying that money. And on the other side of things, there are some who are just genuinely worried about rotating on a knee replacement, and certainly some of my patients, if you watch them swing, and I've seen several who've shown videos of their pre and post knee replacement swing, and they do tend to actually put their foot round a lot more, so they almost hop through as they come through. They don't have that nice smooth motion, and they accept that they aren't going to be the same, but for most people they do seem to get back to it. But the uni group are different. They're fitter, they're more active, and I think there are a whole different group. And your thoughts, Ian?
Well, there are lots of confounders, of course. Some of these studies are quite historical. Patients may have been told not to go back to particular sports, but it's quite interesting to see some of the comparative studies, total versus uni and knee versus hip, where patients do seem to be able to get back in some of those sports to unis and hip replacements where they don't quite so reliably for knee replacements. And it's a complex movement, the golf swing for the knee.
I'm interested whether in the research, whether there is a breakdown in terms of volume of sport and exercise that people do, and then also on that whether there's an opinion as well from the group. So in my population of an active gym-based people tend to be younger as well. I think of an example of a hip replacement who has taken up being a spin instructor post-op. So he's cycling, but he's doing 3 hours a day, versus the normal person who in the literature might say that they're cycling, but they're doing 20 miles a week. Any thoughts or comments on that?
I think the meta-analysis for the uni showed that people are maintaining activity and increasing their low-impact exercise quotient. I think you're looking at a fairly selected group through the gym because they're very motivated, they're all extremely active. And the example I gave of my friend who skis, he spent the last 15 years being semi-retired and exercising 6 hours a day. That's why he wore his hips out. So he's going to carry on doing it with his hip replacements. So I think these groups are very different, but I'll pass on for the ankle.
Yeah, I think it's a very difficult question to answer, isn't it? And I don't think the literature really answers it. It depends on so many factors. And it's this thing about can versus should, I think, in my mind as well, which is again very difficult to answer. So we can issue guidelines and we can bear in mind the risks associated with possibly overdoing it, and try and come to a balance. But I think it's probably different for every individual, every surgeon, every implant.
Same it really. Clearly the age is going to be relevant for a shoulder replacement. So I have a slightly skewed practice because I do quite a lot in younger people. So maybe in their 20s or 30s, often with a hemiarthroplasty, often we're trying pyrocarbon to reduce wear on the glenoid side. But within that group, there are a number, as you say, who are not necessarily instructors, Pilates or PTs, but they do attend the gym sort of 3 or 4 times a day. Now, it's easy in some respects because a lot of that work that they do, they will do from a cardio perspective, they'll do it from the lower limbs. So you can sort of give them some general advice regarding that. An interesting thing, though, was recently, just through sort of internet and a web-based group, we were asked to comment on a patient who wanted to go back kite surfing after a total shoulder replacement in the late 40s. I can tell you there was absolutely no consensus amongst the surgeons who were asked about whether that should be appropriate or not. There was a lot who were very conservative and a lot who took the view that that's what the patient wants to do, that's their demand. He wants to go and do that every weekend, Saturday, Sunday, down on the south coast, go abroad. That's his choice. But the loading, there's no question. I think just listening to the other talks, if you load more, you are more risk of failure. It's as simple as that from what I just listened to from the other talks.
Again, on the hip perspective, you're not going to get it from the literature. So I think the biggest thing, again, is what did you do beforehand? So lots of these people were doing spinning and things beforehand. Certainly around the hip, cycling is very well tolerated, even at the late stages. So often that's the one thing they have done up until the end. So I wouldn't have a particular problem with that. I think once the implant's osteo-integrated, again, I don't particularly worry about the loading in the same way. And you know, the wear properties of modern implants are so good, I wouldn't have any great concerns.
Sure, I mean, I suppose some of this is about their preoperative condition, and I think the person you described is likely to be in a better preoperative state. That must influence how they do post-operatively. But I would agree with what Marc said, really.
These are conversations we obviously have with the patients preoperatively. And for the elbow particularly, we have other solutions that, for that more active patient, we wouldn't probably consider doing an elbow replacement at all. We would do an arthroscopic debridement and we would probably get a satisfactory outcome for that individual and enable them to keep doing their activities to the same level. So again, it's about patient selection, it's about preoperative counselling. And if there is no other solution, you've tried everything else, then they may have to accept that they're not going to get back to that activity level.
Thanks for the talks. With regard to the hip, in your slide you mentioned no dislocation precautions. Is that after they have crossed initial 6-8 weeks period, whatever, or generally? And second, I'm an arthroplasty fellow now, but a few years ago when I was junior registrar, we still used to use those abduction wedges and pillows in between legs immediate post-op, which have now gone out of fashion.
Yeah, I'm talking about no dislocation precautions at all. In fact, the drive in our institution to stop them was partly because this was the time of the start of rapid rehab, enhanced recovery, and it was actually becoming a rate-limiting step in discharge, the seat that stopped them flexing 95 degrees versus 90 degrees. And actually there's no evidence to it at all. Most of these patients are going to self-regulate over the first few weeks anyway. They don't want to do extremes of composite movements around their hips anyway. And the very, very active patients were artificially being held back and actually getting stiff by the time they came back at 6 weeks. So the drive wasn't necessary to the very, very high-end function early, but it may be a byproduct of that you let them get along at a rate that's appropriate for them, their fitness and their condition.
One of the other things to consider is not only whether the implants are going to wear out if the patient go back to sport, but also some of the safety aspects of having let's say, a hip replacement. If you're a surfer, as many of the guys in Australia are having to deal with, there is a potential implication of dislocating your hip while you're in the surf. It could be bad for your health, as in fact a similar injury and a high-speed ski run could be if your knee or your hip were to fail in some way. So I think that probably needs to be stated to the patient, but rather like many of these things, there probably isn't solid evidence to use.
Just want to make a comment, and it's interesting that we now know what we don't know, which is often the case after these talks, and we all seem to be flying a bit blind in terms of the research and telling our patients pretty similar things in terms of what they can and can't do. I'm just interested to hear from our physio colleagues, because I think it is important that we're all singing from the same song sheet with our patients and we're telling them the same things. Does anyone have a slightly more aggressive or open approach to your patients and just let them get on with it and do what they like?
Again, as a general sort of answer to that, the discussion I often have with the patient is that the surgeons will recommend this, but they've all got a picture on their wall of somebody who didn't.
There is a very good paper looking at the high impact, low impact group who self-selected and how they went on their wear rates, wasn't there? That's the one I think it's worth going back to thinking about that. And they were happier, they had better scores, but their wear rate was double. So I think you pay your money and take your choice. And that's why I put that Freddie Fu quote up, because he said, you have to ask yourself, is the activity you are doing worth contemplating further surgical intervention in the future to allow you to continue doing it? And if you can look yourself in the eye and saying, fine, I'd like a revision knee later, then absolutely fantastic. But if you're not, perhaps you should think twice.
But it didn't seem to me that there was the evidence to back up that comment.
There isn't. Except for that Parrott paper, which shows double the wear rate in the active group at 10 years. And the argument about, certainly there are 5 ski papers actually looking at their midterm outcomes, but they're calling midterm 3 to 7 years. And we know in arthroplasty, we often see wear and losing it's a 10-year plus phenomenon. So there's a huge debate across our whole specialty and across the whole sport and health industry about things like this. So I think we have to be supportive, give as much advice as we can, and they're still going to make their own decisions. They'll still carry on running, skiing, jumping. As long as they don't do pole vaulting, I think we'll be okay.
So would you recommend, I ski with a guy who wears a Mojo, and apart from the fact it takes him hours to go for a pee when we go for a coffee or a beer, would you recommend your patients to buy one of those if they've had a knee replacement?
I wasn't thinking just for knee replacement. The ideal patient for something like a Mojo, which for any of you who just saw that picture, basically it's an external spring. So if you go into flexion, it automatically pushes you back up again. And one of our things in our aging population, they get a bit less fit, they start to get pain, they can't exercise and maintain their quads. It's a cheat. It gives you your quads back. So they bounce. I agree with David, it takes about an hour to get ready in the morning and it's a pain in the neck, and the bathroom can be a problem for them at times as well. But it's functionally a good thing, and in people who are weak post-knee replacement, it doesn't support the joint, but it supports the musculature.
Just wanted to say about, perhaps I didn't say in my talk, but in the ankle and big toe, we have a disproportionately high level of sporting patients. So 80%, 70 to 80% of ankle arthritis is post-traumatic, and there's a younger age group. And just to put in the arthroplasty versus arthrodesis thing into a slightly different context, there are plenty of patients who've got back to elite sport after big toe fusions, and there are a number of patients who've got back to elite level senior, vet sport after ankle fusions, and there is nobody who does that with an arthroplasty.
Can I just ask the upper limb guys whether you have any specific advice about overhead activities, or about, in the case of elbows, sort of round the body? I can't think of the right word, but you know what I mean.
Circumduction. But well, in the shoulder, we're sort of fairly lucky, because most of the time they can't do that when we finish the operation and they've rehabbed, so they don't get that range of movement. So, for example, if you're consenting somebody for a total shoulder replacement, obviously the first indication is pain, but I will say to them that a reasonably good result is your arm up to there. That's about average. Very few people are going to come up to this sort of position. Maybe the younger people with a hemiarthroplasty with a good cuff will, but there's always some limitation in their movement. So, so we have no specific restriction. The restriction is within the implant itself and what it's able to do afterwards. Just in terms of, I was thinking about skiing then, and often patients come and ask us about bracing after. Similar to the patients who've got instability after their dislocations, do braces help? And there's there's variable evidence in terms of bracing post-dislocation. You can apply that to a total shoulder. I don't see there's any harm to it. Perhaps gives some proprioception. It also perhaps just gives them a reminder that they've got something that they need to just be a little bit sensible with, but it shouldn't stop them skiing. But there's no particular restriction with movement once they've been rehabilitated.
For the elbow, we try, and our physiotherapists try to teach our patients to lift close to the body so that you're reducing lever arms. But obviously those sports that we've spoken about, tennis, golf, you're multiplying the moment arm significantly, and that's why I think they're so dangerous. So short lever arms and low loads, that's the best advice that we can give, really. So and bring things closer to the body.
Just an observation. I'm an orthopaedic surgeon from Northampton. The hip replacements in the young people that got back to running, I noticed that you used a ceramic bearing. My concern will be for repetitive sort of running, the risk of fracture. And obviously that wasn't a problem with your two patients.
No. I have one patient who did fracture a ceramic head through running. There are probably a lot of patient factors related to that. A BMI over 40, going back to running suddenly to try and lose weight. But I think, across the board, it's not an issue. They still remain, whether you run or not, extremely rare events.
The commonest reason for ceramics breaking and not putting them in properly, malseating the components, I think it's probably very unlikely. My personal approach is I use highly cross-linked polyethylene rather than ceramic, and I think the wear properties are such that probably the wear is going to be much less of a long-term problem with those modern polyethylenes, and I think probably equivalent results in terms of failure as well. And I think modern bearings are going to change the data on the wear that we've seen from all the different areas. I think modern bearings are going to make a big difference and probably almost take away that as a mode of failure with any luck.
A message for Steve, or question for Steve. You mentioned that there's limitation in range of movement post total shoulder. How far are we away from new prostheses that might increase that?
Well, I mean, it does come down ultimately to the soft tissues. The prostheses themselves, when you put them in, they've got the full range of movement. It's the soft tissues that cause the issues. And if you think for us putting in a shoulder replacement, the first thing that we have to do, we have to open the trapdoor at the front. We take the subscapularis off. We have to put that back. We've got to get that to heal 6 weeks. So you've got 6 weeks where, as physiotherapists and therapists, you have to protect that repair, because the failed subscap equals a failed operation. If you don't have that at the front functioning, your shoulder replacement is dead in the water, really. So we're limited by those soft tissues. You then got the cuff influence, and you've got potential post-operative stiffness. So it's not the prosthesis per se which will limit your range of movement. It is those softer tissues. Now, that said, we're listening to the talk on ceramics. As I say, we're looking at other different forms of head. So we're using some ceramics on some replacements, pyrocarbon, which I'm using. We're hoping that actually, the wear property there will be less on a glenoid in a younger patient, and that you'll be able to rehab them quicker and maintain their function better. But it really comes down to soft tissue at the end of the day with the replacement, not the ball in the socket per se.
Thanks very much.